You're listening to He Said, a Cardiology Board Review Series. No fluff, just facts.
This episode is about mechanisms of arrhythmia. Before delving into mechanisms of arrhythmia, it is useful to review the relationship between the main ion currents in an action potential and what we see on the ECG. We'll start by going over the ventricular action potential, and then we'll move on to the atrial action potential. Phase 0 is depolarization. During this phase, rapid depolarization occurs primarily driven by the inward sodium current INA. Sodium ions, will flow into the cell, quickly reversing the membrane potential from its negative resting state. As the membrane voltage rises, these INA channels close. Phase 0 of depolarization of the action potential corresponds to the start of the QRS complex. Phase 1 is early repolarization. Phase 1 involves a brief period of repolarization initiated by the outward transient current, ITO. This outward potassium current contributes to the early repolarization of the action potential. Then we have phase 2, which is plateau. Phase 2 is characterized by a balanced interplay between the inward calcium current, ICA, and outward potassium currents, IKR and IKS. The opening of the inward calcium channels triggers a mass release of calcium ions from intracellular stores in the sarcoplasmic reticulum, known as calcium-induced calcium release, or CACR, causing a 10-fold to 100-fold increase in the concentration of calcium in the cytosol, triggering activation of the contractile apparatus. While calcium ions continue to flow into the cell, both delayed rectifier potassium currents, IKR and IKS, partially offset the calcium influx, leading to a plateau phase during which the membrane potential remains relatively constant. Phase 3 is repolarization. In this phase, the major contributors to repolarization are the outward potassium currents, specifically IKR and IKS. These potassium currents help return the membrane potential to its resting state by allowing potassium ions to flow out of the cell. Phase 2 and 3 of the action potential determine the QTC interval on the surface EKG. Phase 4 is resting potential. Phase 4 represents the resting membrane potential and is mainly sustained by the inward rectifier potassium current, IK1, which ensures that the cell remains at a stable negative potential. There is minimal movement of ions during this phase. The time needed for the INA channels to recover what determines the refractory period during which no further activation is possible. So those are the phases of the ventricular action potential. Now, what about the sinoatrial node? The main difference is that in the nodal action potential, phase 0 is driven by calcium influx rather than sodium influx. So we'll start with phase 4, then 0, then 3 for this sinoatrial node action potential. Phase 4 is diastolic depolarization. This is a key phase in sinoatrial node action potentials. During phase 4, there's a slow, spontaneous depolarization. This depolarization is primarily due to two main currents, the funny current, IF, and the T-type calcium current, ICAT. IF follows sodium ions to flow into the cell, gradually depolarizing the membrane. Concurrently, the T-type calcium channels permit calcium ions to enter, contributing to depolarization. Additionally, the calcium clock, an intracellular mechanism involving the release of calcium from sarcoplasmic reticulum, plays a role in sinoatrial node's rhythm. Phase 0 is upstroke. Phase 0 of the sinoatrial node action potential begins when the threshold is reached and there is rapid upstroke. This upstroke is predominantly mediated by the L-type calcium channel current, ICAL, allowing an influx of calcium ions, which drives the action potential upward. Then we have phase 3, repolarization. Repolarization in the SA node action potential occurs due to the outward delayed rectifier potassium current. This current enables potassium ions to flow out of the cell, leading to the return of the membrane to its resting state. To summarize, Nodal conduction, which is conduction in the sinoatrial node and the atrioventricular node, is calcium channel dependent, whereas ventricular conduction, conduction in the His bundle, Purkinje fibers, and atrial and ventricular myocardium, is sodium channel dependent instead of calcium channel blockage dependent. So PR prolongation is indicative of calcium channel block, whereas QRS widening is indicative of sodium channel block. That's a key insight. The mechanisms of arrhythmia can be divided now into disorders of impulse formation, such as abnormal automaticity, early depolarization, which is EAD, and delayed after depolarization, DAD. Or you can have disorders of impulse conduction, such as block without reentry and block with reentry. In this episode, we'll focus on abnormal automaticity, EAD, and DAD. So let's start with automaticity. Automaticity refers to ectopic pacemaker activity arising from enhancement of normal automaticity or development of abnormal automaticity. While the cycle length of an ectopic pacemaker becomes shorter than the normal sinus length, automaticity will become expressed. Enhanced normal automaticity. Latent or subsidiary pacemakers and fibers throughout the atrium, coronary sinus, pulmonary veins, atrioventricular valve, atrioventricular junction, and even the His Purkinje system exist. These subsidiary pacemakers are kept from reaching the level of threshold potential needed for depolarization due to the effect of overdrive suppression from the more rapidly firing sinus node. In situations where the rate of the sinoatrial node slows, for example, sinus bradycardia at 40 beats per minute, or a block arises between the sinoatrial node and the ectopic pacemaker site, subsidiary pacemakers can escape suppression, for example, AV junctional escape complex at 50 beats per minute. In enhanced normal automaticity, the underlying ionic mechanisms are still normal, but with changes in kinetics or magnitude of currents. For example, action potentials may occur earlier by less maximal polarization, faster depolarization, or lower threshold potential. Action potentials may also occur more easily due to shortening of the action potential duration, with earlier return to phase 4. Adrenergic stimulation, for example, from cocaine, amphetamines, can also cause enhanced normal automaticity by increasing the slope of the pacemaker potential by acting on the IF, the funny current channels. Sometimes, the discharge from the site of enhanced automaticity can inappropriately accelerate and usurp control of the sinoatrial node, as occurs from a PVC or VT. How about abnormal automaticity? Abnormal automaticity refers to impulses originating in cells without intrinsic pacemaker potential due to the appearance of depolarizing currents during phase 4 in situations such as ischemia. In acute MI, myocardial ischemia and infarction can cause non automatic myocardial cells to be depolarized to the point of reaching membrane potentials, at which inactivation of K currents and activation of ICAL can cause automatic discharge from a non automatic myocyte. This is what happens in accelerated atrioventricular rhythm, AIVR, and VTs that develop 24 to 72 hours after acute MI. This is also the mechanism for accelerated junctional tachycardia. Abnormal automaticity is the mechanism for certain types of atrial tachycardias arising from non-pacemaker cells, namely atrial tachycardia from digitalis and atrial tachycardia from pulmonary veins. Now let's talk about triggered activity. Triggered activity refers to arrhythmias that occur as a result of after depolarizations, which are depolarizing oscillations and membrane potential during repolarization. After depolarizations are considered early if they develop during phase 2, phase 3, or early phase 4 of the action potential, i.e., before full repolarization of the action potential. After depolarizations are considered delayed if they develop during late phase 4 of the action potential, i.e., upon full repolarization of the AP. When an EAD or DAD amplitude is enough to bring the membrane to its threshold potential, the result is a spontaneous action potential called a triggered response. EAD, early after depolarization. Early afterdepolarizations occur when the action potential duration is prolonged, which can occur in bradycardia, long QT syndromes, heart failure, and injury from electrolyte disturbances, acidosis, or hypoxia. The prolonged action potential keeps INA inactivated but allows ICA and IK to interact and produce a spontaneous early depolarization. EADs involve early phase intracellular calcium overload, triggering further release of calcium from the sarcoplasmic reticulum. In cases where the early depolarization reaches threshold, it can trigger a run of extrasystoles. Polymorphic VT and torsade de pointes are examples of early after depolarization. That's a high yield fact to remember. Delayed after depolarization. DADs, which occur in late phase 2, usually reach the threshold for triggering an action potential. They are more common in tachycardia. Although not all after depolarizations reach the threshold potential, those that do can trigger another after depolarization and thus self perpetuate. DADs involve late phase intracellular calcium overload, triggering further release of calcium from the sarcoplasmic reticulum. GADs are the mechanism in digitalis toxicity and CPVT, both of which are bidirectional VT. DADs are the mechanism in most kinds of RV outflow tract VT and LV outflow tract VT. An important note about VT. Most VTs occur via early after depolarizations and delayed after depolarizations. RV outflow tract and LV outflow tract VT occurs by delayed outflow tract repolarizations. Papillary muscle VT, moderator band VT, tricuspid annulus VT, mitral annulus VT, and epicardial VT can all occur by enhanced automaticity or delayed after depolarizations. Here are the 3 VTs that do not occur via early after depolarizations or delayed after depolarizations. First and second, fascicular VT, both the left anterior fascicle and left posterior fascicle VT, and focal Purkinje VT occurs via the mechanism of abnormal automaticity that I mentioned above. Third, in anyone who has had prior MI, the most common mechanism of VT is reentry. This is called scar-mediated reentrant VT and should be monomorphic. Acute myocardial ischemia causes reentry due to loss of the epicardial action potential dome in phase 2. Reentry requires a trigger to initiate the arrhythmia and a substrate to sustain it. The trigger may be a premature ventricular complex, which may be in turn due to automaticity. The substrate may be structural remodeling secondary to an underlying disease process, either a scar secondary to a prior MI or surgical repair, or patchy fibrosis in the setting of cardiomyopathy or hypertrophy. So, to summarize, disorders of impulse formation versus disorders of impulse conduction. Within disorders of impulse formation, you can have automaticity or triggered activity. Within automaticity, you can have normal automaticity or abnormal automaticity. Disorders of normal automaticity are sinus tachycardia, sinus bradycardia, sinus arrhythmia, and sick sinus syndrome, which we didn't cover in this episode, and it's covered in a different episode. Disorders of abnormal automaticity are ectopic atrial tachycardia, accelerated idioventricular rhythm, and Purkinje VTAC. Then, in terms of triggered activity, you divide those into early after depolarization and delayed after depolarization. Early depolarization is something like torsade de pointes, whereas delayed after depolarization can be RV outflow tract VTAC, LV outflow tract VTAC, CPVT, or digitalis toxicity. These are the ones that cause bidirectional VT. Bidirectional VT is delayed after depolarization triggered. Then going on to the disorders of impulse conduction, you can have block and reentry that is unidirectional or bidirectional block without reentry, or unidirectional block with reentry. Examples of unidirectional or bidirectional block without reentry are all the AV blocks and bundle branch block, whereas unidirectional block with reentry are AV NRT, Wolff Parkinson White, and fascicular VT. That's all for mechanisms of arrhythmia.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.